He's co-founder and CEO of Moleculera Labs in Oklahoma, which is a neuroimmunology laboratory that focuses on diagnosing neurologic, psychiatric, and behavioral disorders triggered by autoimmune responses. His work spans all stages of research and development. He received his PhD in molecular biology from the University of Tulsa and his MBA from Northwestern University Kellogg School of Business. He's an adjunct professor and senior entrepreneur in residence at the University of Oklahoma and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. So we'll be listening to him for about 45 minutes, and then you'll see a Q&A button at the bottom of the screen, or a chat button. I think that actually we'll be having the questions in the chat today, please. So please enter them there, and then we'll ask them in the 15 minutes or so at the end. Thank you very much indeed. I'll switch off now and over to you, Craig. Thank you.
Thank you, Jillian. And it's a pleasure to speak to you all. And thank you, Martin and AONM and all your colleagues there for spreading the word. What I'd like to share with you is something that we believe is really significant, not only biologically and medically, but also impacting lots of lives. And it's a bit complex, so if you'll bear with me as I walk through some of the science and the biology. And then I know within 2 weeks, you're going to have another talk from Dr. Yannick, which he will talk more about the therapy and the treatments for these different conditions. So what I want to share with you is an overview of this biological mechanism that results in these neuropsychiatric and behavioral disorders, such as PANDAS, PANS, and another term we'll call ANDAL. And I'll explain, if you haven't heard those, I'll explain what those are. And before I start, just a disclosure that I am the president and CEO of Moleculera Labs, and we perform the Cunningham panel, which I will speak to a study about it, but everything that I will share will either be peer-reviewed, published information, or studies that are in preparation for manuscripts. So today I want to talk to you about a little bit about Lyme and the clinical challenges with these neurologic, psychiatric, and behavioral disorders. I am not going to speak a lot about Lyme and the syndromes because AONM has had multiple great speakers and talked a lot about the clinical manifestations. What I want to talk about is the connection between this and these neurologic, psychiatric, and behavioral disorders, and about molecular mimicry and the biological mechanism in which various infection-triggered autoimmune conditions can occur, including through Lyme, strep, mycoplasma, and many others. And then I want to share a little bit more about the medical models of what PANDAS, PANS, and Cunningham chorea are, and how we may be coalescing these into a broader category called basal ganglia encephalitis. And then I'll share with you another term that is known as ANDAL, or autoimmune neuropsychiatric disorder associated with Lyme. And then I want to share with you some of the studies about the anti-neuronal antibody biomarkers and cell stimulation assay that the Cunningham panel measures, and its use as an aid in the diagnosis of basal ganglia encephalitis. And then close with a summary, a little bit about how to wrap this up and what the takeaways are from here. So briefly about Lyme, which you're familiar with, it's acknowledged that it's greatly underreported, and in some cases it's believed that these tenfold greater incidence. So for instance, in the United States, the reporting to the Center for Disease Control, or CDC, is about 30,000 cases a year. But the CDC has also acknowledged that the potential estimates really are approximately 300,000, or in some cases more, each year. And I would say that that probably could be applicable to the UK and to England, where this particular study just showed the increase by 42% within 4 years And so you can imagine that the prevalence of Lyme is actually much greater than people might think. And you've heard before that Lyme, with the causative organism being Borrelia burgdorferi, this particular slide is just to emphasize that the organism has a life cycle that has upregulating and downregulating different types of proteins. These, particularly these outer surface proteins, which we'll briefly talk about in a little bit. And this is potentially one of the reasons that the challenges for these antibody detection methods can be difficult. And the second part is that co-infections are very common. So individuals with chronic Lyme disease often have more than one infection, and most often these that are listed here, but there are many more, which I'll talk about in a minute, such as B. babesia, Bartonella, Ehrlichia, Mycoplasma, Rocky Mountain spotted fever, and Anaplasma. So we can move to then the clinical challenges with neurologic, psychiatric, and behavioral disorders. It has to do with how they actually are diagnosed or classified. So various types of neurologic, psychiatric, and behavioral disorders are symptom-based. And so patients with various types of symptoms are then placed into these symptom-based categories. And so, for instance, if an individual has motor tics and vocal tics for more than 12 months, by definition, that individual would be diagnosed with Tourette syndrome. Various other types of symptoms, such as those that would get a person diagnosed with ADHD or autism. Because these are clinically diagnosed, meaning that they're symptomatic and they're identified by symptoms, often you can find and realize that not all symptoms are the result of the same type of etiology. So the second issue is that we also know that we have interaction between the different organ systems in our body. So they don't function independently. And of course, that's great news, but it makes it much more complex. When we think of the immune system now, with the digestive system, including the microbiome and gut dysbiosis and various types of compounds that are secreted from these organisms that impact the immune system. Also the immune system's involvement with the endocrine system. But what I want to focus a little bit more today is the immune system's involvement with the nervous system and how this interaction actually is involved by infection triggers. So one other unintended clinical challenge of medical specialization is that our prevailing understanding of disease biology. And it's been great that we can get specialization in medicine where many of these complex or really difficult to identify and understand systems are now focused on, such as infectious disease, psychiatry, neurology, and immunology. However, we also know that these are not separate from each other in the case where infectious diseases impact, and we'll talk more about this, psychiatric disorders, neurological disorders, and even the immunology component that's involved with it. So what we really want to see is that the treatment is for an individual rather than treating a disease. And I believe that this is really the focus of functional and integrative medicine, is that you're treating an individual and looking for all the underlying roots. The good news is that major medical journals are acknowledging a connection between infections and neuropsychiatric disorders. So last year in March, JAMA Psychiatry published this 1 million case study that was following children from birth to age 18. And what they found was, through all these medical records, that if an individual was hospitalized for a severe infection, that they were 80% more likely to be diagnosed with schizophrenia, autism, OCD, ADD, and a host of other mental disorders or neuropsychiatric disorders. And they said that this provided the compelling link, or at least epidemiologic link, that severe infections are linked to the onset of neuropsychiatric illness, at least in children. And so in their editorial, they posed the question, how could exposure to infections affect the brain mechanistically to give rise to mental disorders. And the comment was that circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation, and its mechanism has been proposed in PANDAS and other mental disorders. And this is precisely what we'll speak more about here and talk about these anti-neuronal antibodies that cross the blood-brain barrier and then bind to specific neurotransmitters and influence and affect the cognitive functions and the neurologic functions of these individuals. So what I need to do now is to move over to talk about molecular mimicry. And molecular mimicry is pretty much an old biological mechanism that's been hypothesized, but also now has been identified and demonstrated for many infection-triggered autoimmune neuropsychiatric disorders, as well as other chronic illnesses. And so the question is, what is molecular mimicry? Well, those that are in armed forces understand the term friendly fire. And friendly fire is basically where our own immune response begins to attack ourself. And this is sort of the general definition of an autoimmune disease. Well, the interesting thing about this is that there are a lot of relevant genes that have been identified or looked for, but the majority of these genes fall into these major histocompatibility complexes and the HLA antigens, the class 1 and class 2. And these particular genes are involved in the self-non-self recognition and in activating T cells, activating B cells producing antibodies, activating T cells. And so what you'll hear more with Dr. Yannick, we'll be talking about those particular types of mechanisms. So if we think about this at a molecular level, molecular mimicry occurs when we make antibodies against similar, what we call epitopes, between infectious organisms and self-antigens. So you see a bacteria here, and let's just say that's a strep bacteria. And then you see a particular protein, we'll call this the M protein. So that particular protein has a peptide amino acid sequence, which we call an epitope. And basically an epitope is just a part of a molecule to which an antibody attaches itself. So as we make antibodies against particular proteins or organisms like bacteria, and we're probably familiar from the news about the different vaccines that are being made now to the SARS-CoV-2, they take different parts of the organism or messenger that's encoded for those parts of the protein to be able to make these particular epitopes or these antigens that these antibodies are made and directed towards. Well, what we do know is that various types of T cells, B cells, and then also cytokines are involved in the upregulation and the production of these antibodies. Let's say, though, that we, in this case, a neuronal cell, of which it has a similar epitope on some of these proteins that are on and surround or maybe receptors in the brain. Well, when that happens and an antibody has been made against a particular epitope that is similar between a neuron, those antibodies are called autoantibodies, meaning that they recognize self. And this is really the basis of molecular mimicry. So an autoimmune response that occurs through an infectious organism or an external trigger that has a common epitope or a similar epitope that the antibodies are made to, and the T cells or the B cells in this case, they don't recognize that it's self. So if you look at the mechanism that is proposed, and as you saw in JAMA Psychiatry, this autoimmune mechanism for many different neuropsychiatric and behavioral disorders, it starts with microbial, viral, fungal infections, parasitic infections too. And as I mentioned, our body will make antibodies that produce and recognize these infectious agents. But in some individuals, again, the word is some individuals, these antibodies that they make cross-react with the neurologic receptors in the brain. And this is through the process I mentioned of molecular mimicry as one of the mechanisms for doing this. And what results from that is that these antibodies interrupt the normal functioning of specific components in the brain and they through friendly fire, and they interrupt and cause and trigger many of what we see as these neuropsychiatric symptoms. They could be anxiety, aggression, rage, OCD, tics, depression, hyperactivity, etc. And treating them symptomatically results in the use of neuropsychiatric drugs. And so, not that these are not necessary, and of course, many of them are very helpful, but if the underlying root cause is an infection-triggered autoimmune condition, these types of symptomatic treatments are not very effective. In fact, in some cases, they can be deleterious. We also know that there are other autoimmune disorders that are associated with infection triggers through this mechanism of molecular mimicry. And you can see the list here. It's a paper published by Cusack et al. And Guillain-Barré, Sydenham chorea, lupus, MS, cardiomyopathy, diabetes. You can see the list and the putative organisms that have commonality, or organisms that have a similar epitope. So we'll look at one, Guillain-Barré syndrome. And what we see is that the particular GM1 component, which is a lipopolysaccharide, is very similar to that which is on Campylobacter jejuni. And so what you see is that many of the individuals who develop Guillain-Barré syndrome have been post-infectious or after an infection to Campylobacter jejuni. We've also seen it with influenza. And so you're looking for these kinds of common epitopes that an antibody is being made against. And again, it has to do with a genetic predisposition. And so because the question would be, well, why doesn't everybody have these autoimmune conditions when they're based, or these are given to everybody, or they're all infected with, let's say, Campylobacter? It's because individuals have a genetic predisposition that may trigger this with the recognition and non-recognition of self versus non-self proteins. So we also know that there are other infectious triggers, and I mentioned some of those. These include strep, which we'll talk a little bit more about how that's related to PANDAS. The S on PANDAS stands for strep, influenza, varicella, mycoplasma, etc. And interestingly now, what we are seeing and what we believe is the case is that the COVID-19 and the SARS-CoV-2, we are seeing these post-infectious neurologic and psychiatric syndromes, like the Kawasaki disorders, Guillain-Barré syndrome, psychosis. And through these published studies, we believe, and we're working on a grant to study this with the Cunningham panel, is that these targets may be similar because these symptomatic components may be a result of antibodies that were directed against the spike protein, of which there is a common epitope, and some of these neurologic receptors in the brain. So that is something that we hope to be able to look at in greater depth. But there is some studies that are very well known and published about the molecular mimicry between group A streptococcal antigens and self-antigens, and that's well documented. So you see at the top here, a streptococcal bacteria blown up here. You're looking at both the group A carbohydrate and what's called the M protein. And the M protein is a surface protein that's on the outside wall of the streptococcal cell wall. And through molecular mimicry, what is known and what has been published is that some individuals will develop different types of post-infectious streptococcal conditions, such as those that impact the basal ganglia, such as Sydenham chorea we'll talk about, PANDAS we'll talk about, heart valve, which rheumatic fever is one of them, various types of joint pain, kidney impact. But it is also now identified that the outer surface protein A of Borrelia burgdorferi is very similar and has common peptide sequence to the M protein of strep pyogenes. And so therefore you would expect, we do see very similar symptoms, such as those that would occur with those patients that have post-streptococcal types of autoimmune conditions. In fact, a recent publication here was identifying that the epitope, or this outer surface protein A, Borrelia, is identical or very similar to an epitope for the M protein in Streptococcus pyogenes. And the comment here in the discussion was the anti-IgM, anti-Borrelia burgdorferi response in NZB. These are mice. These mice also cross-reacted with Strep pyogenes M protein and myosin, both of which share sequence homology with Borrelia burgdorferi outer surface protein A, suggesting a role for molecular mimicry in the generation of these antibody reactivities. And these findings are consistent with prior evidence that immune responses to infectious agents may lead to deleterious autoimmune phenomena due to immunological cross-reactivity of bacterial epitopes and cell components. Again, the notion of molecular mimicry playing a role in these infection-triggered autoimmune conditions. So let's shift a little bit here to PANDAS, Sydenham, Korea, as a potential medical model for what we call basal ganglia encephalitis, or BGE, or autoimmune encephalopathy. And then in another term, you may or may not have heard about, an autoimmune neuropsychiatric disorder associated with Lyme, or ANDL. So what is PANDAS? PANDAS, if you haven't heard or known the acronym, is Pediatric Autoimmune Neuropsychiatric Disorder associated with streptococcal infection. And so there's a couple of terms in here that we'll focus on as we talk about the differences and the similarities. But the history of PANDAS was a group that was led by Dr. Susan Sweeto in the 90s at the National Institutes of Mental Health. And they studied groups of children that had sudden onset of OCD and behavioral change after a strep infection. And that coined the term PANDAS, in which they studied at least 50 cases of those, and that was published in 1998. What they did find, though, was that other types of infections preceded this sudden onset of OCD in children. However, what they did was they selected to study patients that had an occurrence of strep. And of course, if you know in research and any kind of studies, you want to select a homogeneous population because you want to be able to make some conclusions that are true for all these patients. They did indicate that they saw those with influenza, other types of infections, and yet the term PANDAS, as you see with the S, refers to streptococcal infection. So they set out a criteria, and that diagnostic criteria was abrupt and rapid onset of obsessive compulsive disorders, usually meaning 24 to 48 hours, or severely restricted food intake and the presence of at least two of the following. And they refer to severely restricted food intake as more of an OCD, fear of food contamination or fear of choking, rather than what might be a true anorexia. The other would be at least two of the following: anxiety, emotional lability and depression, irritability, aggression, and or oppositional defiance or behavior, behavioral regression, deterioration in school performance, sensory or motor abnormalities, and other types of symptoms, which include sleep disturbances, bedwetting, urinary frequency increases, and things that could not be explained by other conditions. So PANDAS, as you might guess, is sort of a rule out disorder, meaning you're looking for other types of causes versus looking at this as the primary diagnosis. In this case, PANDAS, P being pediatric, the average onset is about 6.5 years for ticks, 7.4 years for OCD. And as you can see, the boys outnumber the girls about 2.5 to 1. So PANDAS has been around, the acronym has been around, but the interesting thing is that infection-triggered autoimmune neuropsychiatric disorders are not new. So back in 1894, Sir William Osler described these bizarre and precipitate behaviors in children, termed chorea minor, and made that relationship between OCD and then strep infection. Sydenham was named after Thomas Sydenham, who reported this first in 1686. And so this has been around for quite a long time. And Sydenham chorea, we believe, and many people believe, is a medical model for PANDAS and PANS and other neuropsychiatric disorders. This is actually a drawing of an individual with Sydenham chorea having uncontrolled motor movements, and it's triggered by a group A streptococcal infection, where the autoimmune reaction is attacking or involving the brain. So the term chorea was referring to these dance-like movements where it looks like almost they were choreographed, but it was also known prior as St. Vitus's dance. And so it was characterized by these abnormal movements, loss of fine motor control, and even loss of emotional control. So Sydenham chorea is really the neurologic manifestation of rheumatic fever. So what happens is the group A strep, when patients are developing antibodies against them, and these particular epitopes they're made against actually are common or similar to the heart valve, you see rheumatic fever occurring. And of course, the treatment is antibiotics. But we also see, and in those patients, Sydenham chorea, which is the neurologic manifestation of rheumatic fever, and that these antibodies are attacking the brain. And as you can see, the emotional control in those was a sign of that. So if we look at the nomenclature, it's important, but also it can be really confusing. PANDAS, pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection, leaves out other microbes. So Lyme, Mycoplasma, Babesia, Bartonella. If you have those, but you don't have strep, technically you don't have PANDAS, even though you might have all the other symptoms. And also it's believed that there can be other environmental or biological factors that could trigger this. So you have these two different potential triggers, these non-infectious and these infectious triggers. In 2015, actually a consensus was published by a group from the NIMH and Stanford and many of the other research institutions that got together and coined the new term called PANS. PANS was, again, you see the term pediatric, referred to acute onset neuropsychiatric syndromes, but then included all infectious triggers, non-infectious triggers, and it was referred to as pediatric versus adult. So if you were an adult and you suffered from these same syndromes and you might have had Lyme or strep, you wouldn't be diagnosed with PANS because it's a pediatric diagnosis. Another term called ANDL, which is autoimmune neuropsychiatric disorders associated with Lyme, was coined by Dr. Amri Katz. And that pretty much encompassed the rest of things because it did, in fact, in that case, it was referring to adults, but also children. But then it didn't leave out adults. And so more recently, but it's been around, the term basal ganglia encephalitis, which is children, adults, PANDAS, PANS, ANDL, and all these other terms. But the focus is that these antibodies, autoimmune antibodies, are attacking the basal ganglia, causing an inflammation in the brain, triggering and interrupting neuronal signals. And various publications have described it, but one just June of this year in Dr. Cunningham's lab describing this associated with both strep, Sydenham, chorea. And Dr. Amram Katz, who is a neurologist, shared this information, clinical and laboratory features of patients with ANDL in 112 patients that he had collected from treating them from August or from 2013 to August 2015. What he found was there were persistent IgM outer surface protein A antibodies. And as you recall, these later journals have identified this common epitope in this OSPA protein. 101 of the 112 patients had a positive anti-neuronal antibody panel, or a Cunningham panel, of one or more of the 5 tests were positive. So 90.2% of the patients had and showed these autoimmune antibodies or these anti-neuronal antibodies. He also found that these patients had the HLA isotype here. And he also described these involuntary movements upon examination, and that he indicated that there were evidence of damage to both the peripheral and central nervous system on a brain MRI, an EMG, and an NCV, or a nerve conduction velocity test. So if we look at this PANDAS ANDL connection, PANDAS again meaning pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection, and ANDL, an autoimmune neuropsychiatric disorder associated with Lyme. There really are many commonalities, and if you throw in the other terms, autoimmune encephalopathy, autoimmune encephalitis, autoimmune basal ganglia encephalitis, the terminology can be confusing. And what we want to do is see what are the commonalities and what are the differences. Well, each of these are referring to infections triggers, or in some cases, potentially non-infectious triggers. But we see most of this being described as bacterial, viral, parasitic, fungal, possibly environmental. That it is an autoimmune condition, meaning that it's mediated through the adaptive immune system, meaning B cell involvement, potentially T cell involvement, autoantibodies, etc. And then they result in these neuropsychiatric symptoms, OCD, tics, eating restrictions, and you saw the list there. And what we have seen and has been published directed against portions of the brain, particularly the basal ganglia, which is involved with emotional control, cognitive function, movement, etc. And then for PANDAS, it is focused on the acute onset. PANDAS and PANS focuses on this chondroid onset, which is lightning-like within 24 to 48 hours. But the acute onset is not always observed clinically in many patients, meaning it may be over time, but definitely there is a beginning, and that there is a time in which this full-blown disorder has actually occurred. As you can see, PANDAS is limited by age because it's pediatric, which is why the desire here would be to move to something like basal ganglia encephalitis terminology, where we don't restrict or limit the categorization because they didn't fall into some of these different criteria. So I'm going to move over to the understanding and some studies about these anti-neuronal antibody biomarkers and a cell stimulation assay that's in the Cunningham panel as an aid in the diagnosis of basal ganglia encephalitis. So remembering that these disorders are clinically defined, and it's helpful to have some biological evidence to identify whether or not these clinical symptoms are due to an underlying biological component that is autoimmune. And so this, again, is not a diagnostic, but it's an aid in the diagnosis of a physician because these are clinical diagnoses. So I want to just talk briefly about the biomarkers, or these autoantibodies that are measured by the targets. There are 5 in them, and this has been the background of about 15, 20 years of research. And there are 5 targets here. And I'll talk more briefly about them in just a second, but just to tell you what the terms are: dopamine D1 receptor, which is in the brain in the basal ganglia; dopamine D2L receptor, which is also there; anti-lysoganglioside GM1, and if you recall, we talked a little bit about that in the myelin sheath around the nerves; and then anti-tubulin, which is an intracellular structure highly concentrated in the brain, in the neurons in the brain; and then a special assay we call CAM kinase. It's actually an enzyme that's involved in the upregulation in the brain of neurotransmitters, dopamine, epinephrine, and norepinephrine. So I'll come back to this in just a second, but let me share with you just a couple of case studies. So we have over 200 of these case studies in which patients have been tested before and after treatment. In fact, the one I'm going to show you in just a little bit has 58 cases. I'm going to show you just a couple of them here. This was a 9-year-old girl who presented with a known origin of neuropsychiatric symptoms. They knew that she had Lyme disease. She was positive on a Western blot. She had a whole host of symptoms. In fact, we have a case study that's in manuscript form that we expect it to be accepted once we finish and reply to the reviewers, probably within the next 90 days. She said, "Mom, something's happened to my brain." And you can see here that 3 of the 5 were positive. And the criteria for positive is 1 or more positive anti-neuronal antibodies. The patient was treated for the Lyme with Zithromax, Naproxen, Omnicept, Bactrim, Tindamax, and then also 3 IVIG treatments for the immune system, and the patient had complete symptom regression. And you can see the post-treatment test, all of her antibodies were back in the normal range. This is another young man, and we have others that are in adults and young adults, but he presented with 30 days post-confirmed strep infection, onset of OCD, tics, couldn't concentrate, emotional ability, developmental regression, started bedwetting, dysgraphia. And in this case, you can see 1 of the 5 were positive. And this was the CAM kinase assay. I'll talk a little bit in a moment how often that is an indicator of an early or recurrent or a recent infection. The treatment, the patient had 1 IVIG treatment, and within 1 month, they were also treated for the strep, and they had complete symptom elimination. And you can see all the antibodies were back in baseline. So let me focus a little bit on these individual targets and what their functions are. So the dopamine D1 receptor and the D2 receptor, which are in the brain, they are involved with different types of regulatory or neuronal signaling, pre and postsynaptic. And the antibodies that are made can be acting as either antagonist or agonist, meaning antagonist meaning they can inhibit the function of that particular receptor, and an agonist as if it was acting as a drug, as dopamine itself. And what we see is that when patients have antibodies directed against their dopamine D1 receptor, we see a predominance of mood dysregulation, depression, anxiety, poor concentration, delusions, even psychosis. Half those patients will generally have OCD, and half of them will also experience some sensory or motor abnormalities or sleep disturbances. And then when D2 is positive, typically we see that with more movement disorders, motor or movement disorders, including these choreiform movements, we call them piano playing movements, hyperactivity, impulsive behavior. Over 60% experience sleep disturbances, behavioral regression, and OCD. And over 50% again of those have sensory or motor abnormalities. And that's for the D1 and the D2 positive receptor, autoantibodies against that receptor. Then there's the lysoganglioside GM1, or antibodies directed against this lipid component of neuronal cell membranes that's found in the myelin sheath. If you remember that particular image, that when they're made against them, actually what we see is they interrupt the electrical signal, They can cause other types of symptoms, but mostly what we see is tics, whether it's motor or vocal tics, connective tissue pain, a lot of sleep disturbances and OCD, and again, sensory and motor abnormalities and behavioral aggression. A little bit challenging because often many of these have more than one antibody positive, but to the best that we could do, we're looking to try to identify what may be these symptoms that are associated with positive individual autoantibodies. Then we come to the tubulin. It was historically believed that tubulin was just a protein that was a housekeeping protein. But what we find is anti-tubulin symptoms, because it's highly concentrated in the brain, patients have brain fog or this disengaged tune-out struggle with memory and comprehension, aggression, rage behaviors. And you can see the list here. I won't need to go through all of it. And then antibodies in the CAM kinase. It's actually the enzyme that upregulates the synthesis of dopamine, epinephrine, and norepinephrine transmitters. You can see the sympathetic nervous system activation, fight or flight behavior, and involuntary movements can be brief. What we see when they're positive is that there may be and appears to be a correlation with a reactivation or a new activation of an infection. So usually when this is positive, we suggest that you look for underlying clinical or subclinical and multiple infections, and usually they're the ones that were listed, to identify if there may be present in the patient that's stimulating these autoantibodies, because the key is to treat the infection and the immune system. So real briefly, I'm going to go through this study that was published in March, or February rather, in which we identified 58 patients who had pre and post Cunningham panel tests, and those patients either improved or didn't improve based on treatment. We weren't studying the treatment at this point per se. We were looking for the correlation of these antibodies with symptom presence or symptom absence. So you can see from group 1 and group 2, group 1, the patients actually improved and got well. Group 2, they did not, or they got worse. And you can see all of these very similar symptoms across the board for all of them. And these were consistent with PANDAS and PANS diagnoses. And the interesting point here is that many of them had multiple infections. You can see Lyme, you can see Mycoplasma, you can see Strep, Babesia, Bartonella. And again, it goes back to the point that many of these patients have more than one infection. Looking at the statistical differences between those in group 1 and 2, there was none. Patients were about the same age, there was about the same percentage of gender, and about the same time between the first and the second test. So if you look at the heat map of all the patients that were in group 1 who presented before their treatment, who had symptoms, you can see the heat map showing they had one or more positive antibodies. Post-treatment in that group that got well, you can see the dramatic reduction in the total number of antibody positives for these targets. Conversely, with those that are in group 2, you can see that they also had antibodies, but there was a small group of people that actually developed antibodies later. And even though they were treated with certain types of treatment, they actually did not improve. And actually, you can see here an increase in the number of positives, and that those patients had antibodies which correlated with their symptoms. So what we looked for is what was the accuracy of these testing compared to symptoms, which was 86%. We began developing an algorithm to be able to weight these differently. And we identified that we can increase the accuracy up to 90% with a sensitivity of 88%, a specificity of 92%. The good news is that when patients are treated properly and diagnosed properly, that they recover just phenomenally. This is Adam, who was diagnosed with ADD. He was going to be put into an institution. Immunologist requested a test. We tested him, he got treated. And just months ago, after many years, his mom sent this picture to us saying, Adam's running cross country. He's 10,000 times better. So the question here is, are we looking at the tip of an iceberg? PANDAS, PANS, ANDL, BGE, maybe models for portions of many other neuropsychiatric disorders. And again, this could be very beneficial for patients who have these chronic debilitating disorders that aren't responding to treatment. So let me close with a few thoughts, kind of summarize this. Infection-triggered autoimmune neuropsychiatric disorders are complex, but they are treatable. And I want to share what's called a TAC law that I've heard from Dr. Sidney Baker, which is slightly modified here. This TAC law, first TAC law, is if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. The treatment for TAC sitting is TAC removal, and search for the root, treat the cause rather than treat the symptoms. And then TAC law 2 is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. Complex conditions are complex, and to be effective, you have to address all the underlying issues for resolution. And this is why it's important to identify all co-infections. And as you remember, many of these patients have multiple infections. So you're looking for co-infections and other offending agents and pathologies to treat them all, because correctly diagnosing the root is critical to prescribing the correct treatment. So the good news again is that existing treatments have effective responses, and Dr. Yannick will be talking about some of those in a couple of weeks. They fall into these 3 categories, and they can be allopathic, naturopathic, but they generally are anti-infectives, anti-inflammatories, and immune modulators. And then on the allopathic side, you know, these anti-infectives can be antibiotics, antivirals, antifungals, antiparasitics, but they can also be natural products. In fact, many of the antibiotics are for fungal metabolites, which is a natural product. They also fall into anti-inflammatories, which can be also various types of natural products, steroids and non-steroidal anti-inflammatories. Immune modulators, again, the use in allopathic medicine is plasmapheresis, IVIG, and even rituximab, but many other natural products can be immune modulators. And we'll leave this to your other practitioners to describe and talk of them. And then, of course, there's symptomatic treatment, but once the infection and the inflammation is addressed, cognitive behavioral therapy, and even low-dose SSRIs. So if you're looking for some background on it, there are remarkable responses and treatment guidelines for those with PANDAS, and there is a 3 set of articles on the use of different types of immunomodulatory therapies and other types of treatments. And you'll look forward to the talk in 2 weeks that will talk about other types of naturopathic treatments. And other information, including Dr. Bullmore, who is there in Cambridge, a book called The Inflamed Mind, Saving Sammy, about a story, well, it's actually the life of a child who was took a long time to be diagnosed with PANDAS, but antibiotics cured him. Brain on Fire, about anti-NMDA receptor target in the brain, and then a DVD called My Kid Is Not Crazy, following 3 families over their life and the struggles that they face with the diagnosis, getting a proper diagnosis for these infectious triggered autoimmune conditions. So I'm going to ask in closing here that you take a look at this image. You may have seen this image, and some of you may have not. Everybody will see something in this image. And just because I can't ask for a response, usually people will see a woman. And when asked what the age might be, many will say, I see a younger woman. Many will say, I see an older woman. And maybe some of you see them both. Usually someone will see the younger woman and others will see the older woman. But if you look at here, for the older woman, you can see that the nose here is actually the chin for the younger woman. And the eye here is the ear for the younger woman, where it's the eye for the older woman. And the nose here is for the younger woman, And this bracelet, which is down here for the younger woman, is actually the mouth of the older woman. And the reason I show this is because we're all looking at the same data. Often we look at the same data, but we come back with different conclusions. And often patients with neuropsychiatric and behavioral disorders are being diagnosed. And sometimes those diagnoses are the wrong conclusion. And it's not always, but wouldn't it be great to be able to identify patients that have autoimmune neuropsychiatric disorders and be able to treat them and see the type of resolution in patients that may have been suffering for many decades, which we do see. So in conclusion, there are also additional information sources, as you can see here, and we're grateful for AONM, who is sponsoring and putting on the seminar, and then also the many other places where you can find information about PANDAS. But also there's Lyme societies, which you can find information about Lyme. And so our mission here at Moleculera Lab is to help change how medicine is practiced for neuropsychiatric and behavioral disorders. So thank you for listening. Thank you for those that are on the front line working and taking care of these patients. We know that you're pioneers and we appreciate your work. We're here to support you. We are doing a lot of research that we hope will help continue to change how medicine is practiced for the future. So thank you for listening, and Julie and I will turn that back over to you.
Thank you very much indeed, Craig. That was absolutely fascinating, and especially the introduction of the Lyme and the mechanisms there, which I think are completely groundbreaking, actually. I haven't heard that from anyone else before. So quite a few questions, or at least a few, came in prior to this. So I'll ask them first of all, if that's all right. And some of them I think we may need to devolve to Dr. Sam Yanuk, who's with us in 2 weeks' time on the 3rd of December. One of them is, are the symptoms which you describe related to Lyme likely to disappear if the Lyme has been successfully eradicated? I think what she means when she says the symptoms, she actually means the neuropsychiatric ones.
Yes, so regarding the neuropsychiatric symptoms, generally a patient can and does see some improvement, but again, remembering that the Lyme is actually triggered in those cases where there's neuropsychiatric symptoms, the immune system to produce these autoimmune antibodies. So often you do need to do something to treat the immune system too. And this is why sometimes these chronic conditions persist, even though there's some improvement when maybe it's identified that the Lyme may no longer be there. Now, having said that, if you recall, you see that there's multiple infections. Sometimes the Lyme may be treated, but there may be Babesia, Bartonella, other types of infections that coexist that are also triggering and stimulating these autoimmune antibodies. And this is why it's very good to have physicians who are very well versed in these complex conditions, because you need to treat all the infections and then deal with the immune system if the patient isn't completely well. Now, there can be and probably are cases where when the Lyme is gone, the patient's much better. But I personally have not seen as many of those, because often you'll need to do something with the immune system and with the other infections.
Yeah, I wanted to ask that when you say ANDAL, the L in ANDAL, autoimmune neuropsychiatric disorders associated with Lyme, refers presumably to Lyme and co-infections.
Correct.
The L. Yeah.
The L does.
Yeah. The first part of that question was, what's the most effective way of treating Lyme of this kind, which I presume would be neuroborreliosis. So I think that's a question for Dr. Yanuk in 2 weeks' time.
And I would say, yes, I would defer to him. My background as a scientist and as a research scientist is not a practicing clinician, although we do and see and are aware of what many clinicians do. From a practitioner standpoint, we do help them and help them with both the aid and the diagnosis, but also other types of research and things there. So I will defer those questions to Dr. Yanuk.
Mm-hmm. Another question here is that some parents are unhappy that their physicians here in the UK are putting PANDAS down to just being an inflammatory condition and say they don't believe it has anything to do with autoimmunity or antibodies.
Mhm.
And I think there probably the solution would be to maybe with the involvement of another more integrative physician to be would be to refer them to the guidelines that you've just pointed out, the Stanford PANDAS guidelines, and to explain that a lot of research on this exists. They're probably just not aware of it yet here.
Yes, and just to share some information, we've tested now over 10,000 patients in the United States and in other countries. On average, it is not unusual to see many of these patients that come to us have seen between 5 to as many as 15 doctors before they ever found someone who said, could this be something like PANDAS, PANS, autoimmune encephalopathy? Our hope and goal is that this does not occur until you see 5 to 15 doctors, but that it becomes more widespread and known. So two of the things that you can do, one is there are many papers and publications that AONM has, and we have on our website a whole host of physician education. The second thing is that just like many other areas of medicine, sometimes individuals are what we'll call later adopters. So sometimes for the benefit of yourself or your children, to find a practitioner who is familiar with this, who is practicing and knows treatment, and then go to someone while you try to attempt to help educate or help inform others. And it's not too dissimilar that we've seen with other types of conditions. For instance, Helicobacter pylori and peptic ulcers, it was not believed that a bacteria could cause peptic ulcer. And over time and research and studies and demonstration, now it's not just you get a peptic ulcer, you go in for a Helicobacter pylori test, you get an antibiotic and you get sent home. And it's same with many other conditions in medicine. So through the perseverance of your group, Julian and Martin, educating groups, also from parents and individuals, sharing the data and information and scientific publications with their physicians, and then at the very end, making sure that you find someone who's familiar with it and can help you.
Yes, just to mention related to that question, there are a lot of further queries about treatment. And again, we'll introduce those in 2 weeks' time for Dr. Yanuk. So what symptoms have been seen in children post-COVID? And how does this show up on a Cunningham panel?
So we are preparing to do more testing. We're collecting blood and we're writing a grant to be able to collect more blood from post-COVID-19 patients. And it's been reported that they have these multi-system autoimmune or neurologic symptoms that occur. There has been some indications for different types of autoimmune conditions in adults. They've seen Guillain-Barré syndrome, but now there's more reports in the last couple months about post-COVID-19 sequelae, which are these neuropsychiatric and neurologic symptoms. Dr. Cunningham in her research laboratory and us in our clinical laboratory have been testing some, and there is an indication that they do have these antibodies that are not only directed against the brain, but they have antibodies directed against the heart. And so again, you can see that many of these vascular and cardiovascular symptoms may also play into that. So our hope and goal is to continue to raise or win some grants to be able to do the research, to be able to identify those particular targets so the patients can be identified and then also treated properly for those other additional conditions.
Thank you. And the treatment related to that, again, I think we'll ask in 2 weeks,
Yes.
Dr. Yanuk.
And just in general, Julian, those treatments do still fall into the same category. So when it's an infection-triggered autoimmune condition, whether it's attacking the brain or the heart, it is identify the infection, treat the infections, treat the immune system and the inflammation, and those things continue to be able to resolve very similarly. But again, you have to identify all the infections, treat all the infections, the immune system, take care and treat the immune system, however the treatment is, And then whether it's inflammatory, anti-inflammatory, immune modulators, et cetera, you see then these remarkable recoveries in these patients who sometimes have these conditions for many years, in some cases in decades.
Yes, thank you. Could what's often called chronic fatigue or myalgic encephalomyelitis be another symptom of BGE?
Yes, no, that's a great question. And in fact, we do test patients that have those conditions. And what we do find is, and there is other evidence that's been published, that they do have autoantibodies that are directed against their heart, but also against their brain. And in fact, we have seen positive cases with the Cunningham panel with patients who have chronic fatigue, where the brain fog exists. And if you recall the symptomatic condition where the antitubulin and some of these other antibodies are associated with this type of brain fog, they also tend to have these autoantibodies against the heart. We believe that those may be causing the fatigue. Those that are against the brain are likely causing the brain fog. And the resolution has been very similar. Identify the infection, treat the infections, treat the immune system, and patients have some really, really amazing recoveries.
Thank you. Another question here is from a mother who has found, after doing the Cunningham panel, that her son did improve, having been found to have Lyme and likely RMSF, that's Rocky Mountain spotted fever. However, he then relapsed afterwards, and she was obviously moved by seeing your full resolution cases there. But she says, what thoughts do you have about factors that influence full or partial recovery post-treatment?
Right. So in cases, we do see that a patient may relapse upon another infection. And if you think about this from the immunological standpoint, patients will have generated memory B cells. And so these memory B cells, if they are re-stimulated, just like these vaccines, when we get an influenza vaccine, we do it so when the influenza comes, there isn't this time lag because they've already got these memory B cells to make these antibodies. Often these do require some other additional immunomodulatory treatment because, again, the immune system is being re-stimulated. And often when it's adequately and dealt with or treated, we do see cases where patients do not respond to these other infections. So again, this is the importance of working with clinicians who have had experience or are open to understanding and working with other clinicians who have had experience, because relapse is possible. And in fact, often though, it should be caught very early because usually it's another infection or a trigger infection. If you catch the infection and treat the infection quickly, typically what you see is this relapse does not get into a full-blown recurrence.
Okay, thank you. Here, a complex question, I'm sure. What's the antibody decay rate for a person infected with Lyme? And could an infection be identified years or even decades after a person has been bitten?
Yeah, so the pathobiology of Lyme, I'm not totally familiar with, but it would follow many other infectious organisms. The challenge with Lyme is it's a spirochete, and it has multiple life cycles in which it can actually hide inside the cell. So if you remember, it expresses different proteins at different times. And so what happens then is you may have antibodies against certain types of proteins, but the organism may not be completely cleared. So ultimately, there's the full clearance. And I know that you have a partner that does testing for the presence of Lyme and the ability to possibly have a better testing mechanism to be sure that it fully is eradicated. But just like any other antibodies that we develop, we all develop memory B cells, and those memory B cells are there to help us if we get those other types of exposures or infections. The problem, though, is with these cross-reactive ones, where the particular antigen that's made against the Lyme, this particular part of the protein, is actually very similar to a part of our body, and in this case, a part of the brain.
Thank you. I think probably a patient here, or perhaps a therapist, writes that she has an appointment tomorrow with a pediatric neurologist, and she's already heard from him that he would prefer not to use the Cunningham panel because he's seen studies showing that controls are sometimes elevated, have positive markers. I think she's probably talking about the Bechereau study.
Yes.
Which perhaps you could just touch on that, and then afterwards, if you wouldn't mind pinging me over the research paper that I know came out after that, the rebuttal, then we could send that to her and she could take that with her tomorrow. So the person, I won't mention your name, but if you could send an email to us right after, then we'll ping over Dr. Shimasaki's papers, because I know exactly what you're talking about. Perhaps you could just touch on that.
Yeah. As with all science, we want thorough studies with multiple groups. And there is one study from a group in Sweden that was looking at the Cunningham panel in birth controls and cases. Unfortunately, in that particular situation, what was used, to lack of our knowledge, was certain types of tubes that had interfering substance in them. And so what happened is it skewed some of the results. And we did address that with them, and they did print a core agendum that did disclose that was what would happen. However, it does not discount that there may be what we do see on occasion, and Dr. Cunningham has published a recent paper, that in some cases, in some patients, there may be some levels of autoantibodies that could be, in this case, we believe, potentially precursors. So for instance, not only just in the serum, but they have to cross the blood-brain barrier. So when the blood-brain barrier is compromised, then those antibodies can actually get into the brain, and then they become deleterious. So we have published multiple studies, including the one that I've showed you, the correlation between the presence of these antibodies and the absence of controls. And there's been other studies that other researchers have published in autism and even in schizophrenia, and we can share those. But the goal is that patients who are symptomatic with these conditions, they have these antibodies present, and it's used as an aid, which is why I say the diagnosis is the physician's diagnosis. The presence of these are an aid in the treatment and the identification of that diagnosis. Thank you.
I'll just be able to ask one or two more questions, because I think we should probably finish at 10 past. I know you have time constraints as well, but we can, I'm sure, have you back again to answer further questions very soon. That would be fantastic. Here, another question. She's very glad to hear that you mentioned MARCoNS. In clinical practice, she has observed undiagnosed MARCoNS translates to multiple relapses in a child with PANDAS with tick-borne pathological triggers. And she's observed the same in adults as well. Does that make sense to you?
Yes. Again, it goes back to the full and complete treatment for the immune system and the infections. So for instance, if you treat one infection, you might see a reduction. It goes back to that two-tack theory. You don't necessarily see 50% reduction in all that by removing one. So it could be that there are multiple infections that still remain. The other is, if they have been cleared, the immune system may not have been, let's say, reset or calmed down or quiescent. And so those two areas are one component of that. The other is that remembering that these are B cells that have memory, that if it is a patient that actually fully recovered and then is having a relapse, then typically you'll want to address and treat that infection and the immune system very quickly, because it won't give the immune system a chance to fully mount a response. And that is why, even though patients and physicians will treat patients that do improve, what you want to is see a full recovery. And the other is, which is why we've done a lot of post-treatment testing with the Cunningham panel. As you can see in a couple of those instances, when those antibodies are back into baseline, we know that those patients have had that recovery. And so it is also could be a way in which looking at the monitoring of the effectiveness of these treatments. But that is why it makes this kind of a challenging area. And our goal and hope is that there will be better treatments that will be out that will be much more effective. But in the meantime, it's also relying on the clinician to use all these different treatments and modalities at the same time to be able to address all the different parts of this condition.
Well, we will be having in the new year a webinar about biotoxins as well, and new treatments for that. So maybe we could link in when we have you the next time how the Cunningham panel can be used for mold and biotoxins, whether it can at all be in your experience yet. Maybe one last short question. Have you observed any children who sway their heads from side to side prior to sleep? And if so, what causes this particular symptom?
No, I have not, and I'm sure many practicing physicians might be better able to weigh into that. But what you could think of that, if that is a recurring, an involuntary movement, it could be diagnosed as a motor tic. Motor tics can come in all types of shapes and forms, or it could be an OCD, an obsessive compulsive disorder. Many of the things that we do see is that those types of conditions or those types of behavior may resolve completely after the treatment. And if it is, then you can conclude that that may have been a motor tic, or it may have been an OCD. And so we do see a whole host of different varieties of things like that. Now, there is one situation that you might consider. If the patient has fully or believed to be recovered, the infection is cleared, the immune system is treated, and they may have some type of compulsion that still remains. This is where some form of cognitive behavioral therapy can be helpful, because once you've treated the biological component, there may be habitual things that can improve with these other types of cognitive behavioral therapy. Now, the issue is that if you're trying to use cognitive behavioral therapy to treat a biological condition, then that doesn't usually work very effectively. But when you treat the biological condition, the infectious condition, the immunological condition, and maybe there is a symptom or two that remains, these could be effectively treated with CBT.
Understand. Thank you. Well, thank you so much. That was absolutely fascinating. And just to mention that AONM, the Academy, does liaise that test with Moleculera in the States. So if you're interested in finding out more about it, do please look at our website, where we have a tab called PANDAS, and do just call up the helpline if you'd like any further information. If you'd like to follow up on anything related to this specific webinar, because we have had quite a few very specific questions that have come in that I haven't been able to ask you, Craig, then please send an email to info@aonm.org, including that mother who's going to a pediatric neurologist tomorrow morning and needs these papers that we've just discussed, Craig. And we'll send out as much as we can to everybody who writes to us. Huge interest in this talk, Craig, and I do hope we can have you back perhaps after Christmas.
Yeah.
And we'll be having Dr. Sam Yanuk on the 3rd of December at 7 o'clock talking about treatments. So that's going to be very, very interesting indeed. He'll be talking for an hour, maybe an hour and 10 minutes as well. And I know you'll be there in the background as well, Dr. Shimasaki, so maybe you can chip in if there are questions related to what you've just presented. Sure. Thank you so much. Really stunning information.
Thank you, Gillian. Thank you, Martin.
Thank you, everybody as well who was here. Yes. Goodbye. Bye-bye.